Good afternoon, everyone, and welcome to the Drug Reviews and Therapeutic session in the Mirabai Chanu Hall. And our first speaker is Dr. Shailaja Kale, and she will be speaking on glycemic variability. It's a pleasure to introduce ma'am. She is the director of Dr. Shailaja Kale's Diabetes and Specialty Center and Orange Diabetes Foundation. And we all know her from Pune. I think everyone knows her personally as well as a speaker. So over to you, ma'am. And Dr. Neglur sir will be chairing our entire session and taking the discussion forward.
Yeah.
Thank you, sir.
Okay. Welcome Shailaja, and start your presentation.
Hello, Dr. Neglur.
Yeah,
actually, I'm trying to share the screen. Yeah.
Now you'll be able to.
Yes. So I think today we will be dealing with our standard. I think everyone must have heard this topic, and there is a lot of discussion always happens. So I'll be going through some basics and including my thoughts about variability. And so these are the salient features where we will discuss today's all the important points against the implications, how it is related. Is it a cardiovascular risk marker or it's a cardiovascular risk factor? How DPP4 inhibitors are better to improve glycemic variability. So we all know that HbA1c is a gold standard and we need to control HbA1c. So you can't answer the patient that because you have lots of variability, we will ignore. No. So A1c is the first guiding point where we decide our prescription. But at the same time, there are patients who show a lot of fluctuations. And now there are studies that these glycemic excursion affect the whole vascular tree differently, and that's why it is not good. So only A1c is not sufficient. You need to know the 24 hours glucose profile of the patient. That is what is happening throughout the day. So fluctuations means there can be a severe hypoglycemia or there can be huge postprandial peaks, which we know. Especially Indian patients with large carbohydrate diet and the 3-meal diet structure of everyone's day, we face a lot of glycemic excursions. So which actually affect micro and macrovascular complications and impact also psychological. But I think we need to explain, just now there was a patient, HbA1c is 5.9 and he's only on metformin and his glucoses are fluctuating between 90 and 150. And then he told me that he has lots of fluctuations. So for the patient's perspective, it can be different. We really need to see what are the profile. But this is true, these glycemic excursions do affect vascular tree. Let me remind you, those postprandial peaks for a few hours, even in healthy volunteers, they affect the myocardial contractility, they affect the endothelial dysfunction, it can induce inflammatory markers. So these excursions are not good for the whole vascular tree, and we need to do something about it. So how to define glycemic variability? Is measuring these fluctuations, and we have some measures which actually says short-term or long-term. I think in day-to-day practice, when we see these home monitoring charts of the glucometer, and when we do structured glucometer monitoring, we come to know. Now, major issue happened after these trials like ADVANCE. We know that what happened in earlier intensive glycemic control trials, that severe hypoglycemia was associated with increased cardiovascular and overall mortality. It's not cardiovascular, only overall mortality. So a sick patient with 15 years of type 2 diabetes, he has lots of issues and he gets a severe hypoglycemia with whatever treatment we have given. What it tells us that this person is sick and he has a very high chance of more cardiovascular risk or maybe sudden death. So that is for sure. So we should remember that hypoglycemia is always a measure of duration of diabetes and also all the complications of diabetes. So what ADVANCE showed was that even with high-risk cases of cardiovascular disease, known patients, if you have an intensive A1C, we do not get severe hypoglycemia. That's what it's a very kind of a comforting to see the advanced group. So you can have a good A1C in a lot of patients. And it also showed that glycemic variability in that good control, it is associated with microvascular events. DEVOTE, it was a cardiovascular outcome trial with the degludec. Very nicely done glycemic variability studies. I was a part of DEVOTE as an investigator from India. And let me tell you, this variability we measured by 7-point profiles. It was not CGM in DEVOTE. So these are type 2 diabetes around 9 to 10 years duration patients in DEVOTE with high CV risk because it was a CVOT trial. And here, the variability was measured with home monitoring of blood glucose of 7-point profile. And you can see the data, which was so beautiful. If you remember the DEVOTE slides, they divided the patients into low variability, medium, and the high variability. Patients with the high variability have a more risk of hypoglycemia. So more the variability, more is the severe hypoglycemia, which becomes very important in the sick population, that group of patients with longer duration of diabetes, with multiple problems, proteinuria, cardiovascular risk. All these patients will, if they show high variability, there is a risk of severe hypoglycemia increases. Now, even fasting visit-to-visit variability was studied in DEVOTE because it was such a nicely monitored kind of a trial, which also correlates with all-cause mortality as well as CV events. EMPA-REG, again, it showed, I think EMPA-REG showed us that more the variability, its subsequent increased risk. Also, blood pressure variability is not good for the cardiovascular. That's what also EMPA-REG and the canvas, they showed. So all these trials are in sick type 2 diabetes, high CV risk patient. What they tell us that if there is a more variability, my patient is more prone for severe hypoglycemia. As I was saying, we also need to see whenever there is a variability, how old is my patient? Is he elderly? Is he has a long duration of diabetes? Does he have comorbidities? So everything together, we can do risk stratification and monitor the patient more closely. These are the short forms and the NERNs which you will always use, which are used to measure the variability. These are gets calculated by in continuous glucose monitoring, but we do all fasting PP. So the standard deviation is the variation which we know mean glucose. Coefficient of variation is again how much glucose is. MAGE is mean amplitude of glycemic excursion. So the peaks which you see on whatever 15 days time. So where is the mean of the peaks? Conga is again difference between the current blood glucose reading and taken some hours prior. So which is also very important, like when you see at 5 o'clock glucose, what was the postprandial peak and what was the pre-meal glucose? See, every time when we check postprandial, we need to see what was the preprandial glucose. Just by seeing the reading postprandial 320, sometimes we cannot come to a conclusion. So if your patient shows lots of variability and we do not want to do continuous glucose monitoring, we don't want everyday 7-point profile, but once in a while, unless we know pre-meals, we cannot act on the postprandial. Unless we have fasting, we cannot act on the postprandial. So what I mean to say, a structured home glucose monitoring also help to all these, though you may not kind of calculate these one, but you can, you know how my patient is behaving or his glucose as well. So how it is related to glycemic kind of a worst outcome, it is with the hyperglycemic range is associated with adverse event. In 2019, first time, we know that EASD published during EASD, it was one important outcome of that conference where there was a paper was published with more time in range in type 1 patients, again measured with home monitoring of blood glucose, that better the time in range, less is the variability, more protection for the kidneys and the eyes. From those publications, there is a more kind of because we got some clinical correlation of variability. So more the variability, there will be poor time in range. And the better the variability, the time in range will improve. So more the variability, poor time in range, more will be diabetic retinopathy, cardiovascular risk, more chance of severe hypoglycemia, more kidney damage, more cognitive disorder, and also the peripheral neuropathy symptoms will go up. So we need to try and improve the variability by designing the prescription perfectly. So predicting the frequency of hypoglycemia, as I was saying in DEVOTE, the major correlation of variability was with severe hypoglycemia. And this has been seen in many studies, but DEVOTE, because it was done a very nice study with high CV risk patient, we should take that kind of a thing from DEVOTE to change our clinical thinking and use. So it's a major work of variability. What we come to know is that there is a severe hypoglycemia. So we should be always aware for such patients. And as I was saying, the whole vascular tree gets affected by the excursions of the glucose. And short-term as well as the long-term variability will affect the vascular tree by increasing oxidative stress, glucotoxicity, endothelial dysfunction, and microvascular complications, even in that microvascular tree. So everything is not big arteries. And ultimately, when the big arteries and the small tree, they connect together, it's just vascular complications, and you do not have a black and white difference between the micro and the macro. So changes in blood pressure, arterial stiffness, intima media thickness. So all these measures of arterial problems and the arterial vascular issues are related to glycemic variability. And they have lots of small studies, big studies, which have checked them as an outcome. Like as I was saying, healthy volunteers of 18 years of age, when there is an increased postprandial excursion, there is an effect on the endothelial dysfunction as well as the myocardial contractility. So we have that kind of a small studies which are published every now and then. So as we know, a severe hypoglycemia or more glycemic variability is the first independent predictor. It should tell us that this patient is sick. I need to look after this patient more carefully. That's the very important message. First risk is of severe hypoglycemia, and also it predicts more mortality. So we don't know whether it's a cause or it is just an association. This more variability, but the association is strong and has been seen in many of the studies. So it sensitizes a treating physician that this person is sick and I need to take care more kind of a properly for this person. So so if I want to bring down the glucose from A1C 9.5 to 6.5, I need to do it gently. If we behave like it was an ACCORD trial, too many medicines, 1, 2, 3, 4, and I want to bring down faster, it is not good for the patient. If we do gentle reduction, so how we decrease the glucose, that is also very important to avoid such kind of hypoglycemias and variability. Now, we have very good anti-diabetic drugs nowadays, which actually affect variability and improve glycemic variability. So we have all the insulin sensitizers. Let me tell you, even though they are not in the list, the sensitizers, first thing which will improve is metformin, pioglitazone. These are the best drugs which will improve the variability. They make the excursions smaller and our patients. Basal insulins, if used judiciously. All acarbose, we know that it also improves a nice, and there are studies, loads of studies with acarbose, that it improves glycemic variability because the absorption gets flattened. So at then and there only postprandial peaks are flattened with these kind of drugs. DPP4 inhibitors, because of their very good effect in the postprandial state as such, because there is an effect on glucagon as well as the insulin. See, all the other drugs will act only on insulin. Only incretin-based therapies work on glucagon. So DPP4 inhibitor and GLP-1 receptor analogs will have a very good effect on glycemic variability and also the SGLT2 inhibitors. So now insulin and sulfonylureas on one side and sensitizers, DPP4 inhibitors, GLP-1 analogs, and also we have SGLT2 inhibitors. So now we are in a better position to control these peaks and the excursions. So DPP4 inhibitor, we all know, it reduces, improves glucose control without hypoglycemia. It also has an effect on glucagon and also some effect of preservation of beta cell mass, and because it's a gentle effect as well as insulin and glucagon. Plus DPP4 inhibitors show Lots of studies will show that it reduces cardiovascular risk markers like inflammatory markers. Atherosclerosis will reduce. There are studies which show that it reduces oxidative stress, reduces endothelial dysfunction. Those small studies, which may be because it improves the postprandial state as a whole. That's why DPP4 inhibitors are best used to improve postprandial state. We will see a very large number of studies as compared to other oral agents. You can see this graph on the right side that it is glycemic variability is favoring DPP4 inhibitors and it is favoring glycemic variability. So the fluctuations are less when I am, and the first thing comes to our mind when we are using DPP4 inhibitors is safety. They are very gentle drugs, so they are better. So there will be studies done with CGM where vildagliptin will show a good kind of a variability. Let me talk a few words about VERIFY trial, which you must have heard so many times. Even in the newly diagnosed patients where the vildagliptin metformin combination was used for 5 long years, where we all know the very good effects of this combination in VERIFY, very nicely designed trial, what it shows 16% relative risk reduction in cardiovascular risk. And these patients were not high CV risk. So even in those low cardiovascular risk patients, it showed some improvement, which may be running through its effect on the atherosclerosis and inflammatory markers, maybe through reducing glycemic variability. Here it shows actually all these markers of variability has improved significantly when we are treating patients with vildagliptin. MAGE response, again, it is variable. I don't think this is head-to-head comparison. I asked for the paper, but I haven't got it. Lecture with me. So, it is, I think, what I will say on this slide, all DPP4 inhibitors are very good to improve glycemic variability. So to conclude, it should be an important metric. Continuous glucose monitoring is not required every now and then. We can do it with the structured kind of a home monitoring. We don't need a fancy continuous glucose monitoring to know the glycemic variability. But I personally feel continuous glucose monitoring helps a lot to teach patients that how to change the diet and everything. And in few patients, it helps. But a structured home monitoring of blood glucose will be very good to minimize variability and the design of the prescription. Use this incretin-based therapy. Vildagliptin, we have seen lots of good results. All other gliptin, insulin sensitizers, good basal insulin, and we can improve this variability. Thank you.
Thank you, Shailaja, for a very, very crisp talk, very crisp and very nice and a very subtle discussion. There are some questions which crept in my mind as you're talking about all those metrics. You talked about MAGE, you talked about MOD, MODD. All these are some of the expressions which use mathematics, and we doctors are very poor in mathematics. And even when you get the automated readings on the AGPs, sometimes they also wrong. You know, I had seen a patient recently with the sugars about 250, but the variability showed just 20%. So do you think, how do we calculate these variability, number one? And secondly, does it really have any clinical implication? You mentioned about many things in terms of stiffness of the blood vessels and all that. Do you think these are important, that we use all this mathematical expression to calculate and spend our time on that?
I think, sir, I personally feel if you're doing continuous glucose monitoring repeatedly, like a structured way, and if you come across some patients where it is really patient is on multiple insulins and I'm struggling with the glucose control, I do CGM every month apart and show them the improvement. Then only it is of useful. Doing only once, it doesn't mean anything. I prefer structured home monitoring of blood glucose as it was done in DEVOTE, even in clinical practice.
7
So
points.
we give, every prescription has a monitoring prescription and the duration for all my patients. So I think structured home monitoring is more important rather than, as you said, going in these complex numbers. I completely agree with you, sir.
Right. I think, Shailaja, that brings to one more important topic of HEART-2D trial. So this was a trial in 1,000 patients who were randomized to receive either basal insulin or prandial insulin. And they had just recovered from myocardial infarction 21 days ago with the basal A1C of 8.4%. And what did they find? That even in spite of improving the variability, the outcome did not improve. What is your take on that? How do you explain that?
That's why I said in my talk that variability, actually it's only an association at present. There is no causative association. So glycemic variability is associated with increased mortality. And again, it is overall, it's not only cardiovascular. So it is a strong association. We don't know whether the patients get or die because of the variability. Or variability tells us that this patient is sick, he will die. We don't know. So at present, it is an association. We do not have a causative role. Though there was one paper, as I mentioned, EASD published that better time in range will improve microvascular complication. That's the only thing in type 1 patients which we have with us. I don't think there is any other, if you know, I'm like to hear that, but there is no which targets variability and there is an improvement.
No, both the studies are negative. In fact, even the flat sugar study from Washington was also negative. So almost all the data that we have, I think, is negative. So there's nothing to prove. I think only in acute setting, probably, there is a data which says that the variability has an implication, the outcome in the cardiovascular disease, not in the chronic setting. You were saying something, you want to make a point? You just raising your finger.
I agree. Only in the, like, even in COVID, the first paper came from China, is the high variability tells more mortality and more increased hospital stay.
Right.
So yes, indoor patients, ICU patients, variability, again, there also it is an association. It is not a causative association.
Right.
So it is not because of variability someone is dying with COVID. So it just tells, and I think with lot of discussion in clinics by junior doctors, sometimes, see, occasional postprandial peak is okay. If you start struggling with those once in a while, if it comes to 70 and A1C is good, fastings are good, how much importance to be given to that? That is also one needs to go on this side, because it creates a lot of psychological impact to the patient and the quality of life also, because if you start discussing with them all these numbers and figures.
Right.
Also, I have one question about those who use a lot of continuous glucose monitoring. Mangesh, you are also here. There is a lot of discrepancy between these, especially the Libre Pro which we use, with the actual capillary blood as well as the laboratory testing. So all these things just tell us the variability, but actual readings, there is so much of discrepancy in the actual readings and the CGM. I don't know how much it is really useful in clinical practice.
It's going to be requiring time, ma'am, to establish that. And as we are developing our technology, the accuracy is getting better and better. But of course, what simple trick that I usually recommend to my patients, those who we are putting on either with Libre Pro or a CGM, is this, that, at least 2 or 3 times, while you are just checking out on the CGM or the Libre Pro, just reading, also try and do your sugars on the glucometer and just have a check, and just find out if there is any difference or not. So that will roughly give you an idea that how much is the difference between an interstitial fluid sugar as well as the real capillary blood sugar that they are measuring on SMPG. And probably that difference is likely to stay. So with this, probably we may be able to establish little stability in the difference at least, And as you rightly pointed out, that as far as the causal relationship and the glycemic variability is still a long way to go. I am really yet to be convinced about it. Of course, there could be an output or outcome, I would say, association which would be there, but that would be only in the chronic patients, as Niglu sir was talking.
Yeah, I think also, as Shailaja mentioned about the COVID patient and the study from China, which also looked at those who received steroids versus those who did not. In fact, the variability was least in those who received steroids, and they had a maximum problems. So therefore, again, proves the point that the variability understanding is good so far as the dynamics of the sugars are concerned, but so far its implication in clinical practice, I think, is questionable. Shailaja, I think last question, there are 2 minutes to wind up. About the role of exercise and the diet in getting your variability under control.
Yes, actually, that's what I say. I use more of a CGM to control patients' diet. Just to mention in my talk that last sitagliptin and vildagliptin is a head-to-head trial, and which actually showed that vildagliptin is better for variability. I personally feel anything which is more divided doses is better for the patients. And I don't know why vildagliptin people are bent upon getting once a day when it is such a good drug which acts very good in twice a day settings. I think we will not understand the market.
I think the companies are listening to you and they say they will listen to you, but they are also trying to launch once-a-day therapy. In fact, the company through which you are speaking, we're the only one who are not interested in launching.
Absolutely. And in fact, I completely second that point, sir. I really love Shailaja ma'am, the way you have spoken about this. This is the most crux of the whole thing. There are drugs which can give you a better control over the glycemic variability in the split dosage forms. Yes. So why you are jumping onto the once-in-a-day formulation and worsening that glycemic variability again?
Yes.
I don't know. Even glimepiride we use twice a day. Even glycoside, though in advance use once a day, we all use it divided.
No, that is extended release. That is extended release, madam, because that's a different mechanism of action of the drug.
Still, like glimepiride, long-acting drug.
Initially, it was launched as long-acting. Now it has come out to be a short-acting drug.
So every pharmacodynamics are different in every patient, though pharmacokinetics says something. About diet discussion, yes, I think in India, it affects a lot for variability and different kind of food, which we have huge glycemic excursions. So the role of diet is, I will say, crucial to improve those postprandial peaks. I will not use the word variability. I will use the word postprandial peaks, which can be flattened with the dietary changes. Right. And exercise, as it's an insulin sensitizing thing, will have a good effect on overall kind of a control and also the fluctuations, which has a peak effect after 8 weeks of continuous exercise, which starts showing the effect. So both of these things should be used to improve the overall 24 hours glucose burden.
Right. I think, in fact, there was a lot of studies which looked at the medical students also, given the McDonald's food, and they looked at the vasodilatation following the using the blood pressure cuff to see the reactivity of blood vessel, and showed that the decreased reactivity even by just prandial load of the food. And I think there's one question which is in the chat box to you, which is variability association in GDM patients. What is the outcome in those? Dr. Gauri Tamankar is asking a question.
Yes. So in pregnancy, everything is related to how much excess glucose goes in the baby. So rather than variability is the actual numbers, the postprandial peaks, like we see only post-dinner glucose goes up. And even the fasting is correlated. So though we talk a lot about postprandial, so I don't think we should go in the discussion of variability, but we should avoid all the peaks, as well as fasting should be maintained around, I will say 80, though we say the target is below 90. You will see there is a difference in the abdominal circumference and the AFI and the Liker quantity. Everything will go up if the fasting or any of the postprandials are high.
So it is more of staying in time in range, Dr. Gauri, rather than glycemic variability.
No peaks and valleys. No peaks and valleys. Yes. I think thank you, Shailaja, for the wonderful presentation and a very